Dr. Wayne Strauss started his career getting his PhD in bioengineering at the University of Washington, and then went on to do his medical training at Virginia Mason up in Seattle, and then did pulmonary critical care at OHSU. He is currently a neuropharmacology autism fellow. Was, and has a Young Investigator Award. Had. Okay. All right. We'll just jump to what he's doing now, which is he works for the Oregon Clinic Pulmonary Critical Care and Sleep Medicine East, and he's going to be talking to us about pulmonary hypertension.
Yeah. Good morning. Is the volume pretty good? Yeah. Okay. Yeah. Thanks for inviting me. I think it's been about 8 years, so I was expecting that email anytime. And then it came. So yeah, I really love talking about pulmonary hypertension. My two issues are, one, always keeping it under an hour, so I'll try. And then it's getting harder and harder to think of good new, word plays for World Health Organization. So I swear the best I could come up with was "Who cares" this time. So I apologize for that. But hopefully you'll see why that's an apt word play. And then the one other thing I'll just draw your attention to that hopefully I'll get to talk about at the end is obviously I work for the Oregon Clinic, but many of you probably don't know that Oregon Clinic East and West is part of a nationally certified pulmonary hypertension comprehensive care center. And I will hopefully get to show you a couple of slides about what that means. So proud to say we have no conflicts of interest, but we have been we've been clinical sites for trials from pretty much every drug I'm going to talk about. So I'm going to talk about the changing and not so changing face of pulmonary hypertension. And I think the changing face is the therapeutic approach and how the new trial paradigm in pulmonary hypertension. But the most important thing I'm going to talk about, the not so changing face, is the workup of pulmonary hypertension really is still the same. And so if you're just going to pay attention for like 5 minutes and then go back to Tinder or Facebook or whatever on your cell phone, just really the next 4 or 5 slides are probably the most important, particularly for generalist or primary care hospital or outpatient doctors. So just like in great literature, the scarlet letter A really makes all the difference in pulmonary hypertension. And when people can kind of understand that, it really helps you think more clearly about the disease. So what a difference a letter makes. So this slide is probably the crux of the whole talk. So pulmonary arterial hypertension, or PAH. That is a very rare disease, probably like 5 to 10 in a million people. It's a disease primarily of the pulmonary vasculature. And it is an isolated, it can either be an isolated disease or it can be where the pulmonary vascular disease is the pulmonary manifestation of a systemic illness or exposure. And I'll talk more about that as we go on. But diseases like scleroderma or exposure to things like methamphetamine are common. So no matter how you get PAH, it has a common pathophysiology that we'll talk about. There's dysregulation of nitric oxide, endothelin, which is a hormonal signaling, and prostacyclin. And it has very specific treatments. Pulmonary hypertension, or just PH without the A, that is a very common condition. And in PH, generally the pulmonary vasculature is an innocent bystander. And that's where we have high blood pressure in the lungs due to either left heart disease or other types of lung disease like COPD emphysema or interstitial fibrosis or things like that. And this has variable pathophysiology. And distinguishing between PAH and PH is so important because treatment is aimed at the underlying disease state, not the pulmonary vasculature in PH. So I think from a primary care view, whether you're a hospitalist or an outpatient primary care doc, I think the most important thing to remember is that patients who present with that echo report, moderate to severe pulmonary hypertension, the vast majority of them have systolic or diastolic heart failure, they have aortic or mitral valve disease, they have obesity or sleep apnea, they have COPD, and they have interstitial lung disease, amongst other common conditions. And again, it's so important because only the treatment of PAH has been studied in large clinical trials with all the fancy medicines that we use. In other disease states like COPD and heart failure, treatment is aimed at optimizing the underlying disease, not directly at the pulmonary vasculature. So just to step back quickly, the signs and symptoms of pulmonary hypertension. So early on, the first symptom, of course, is dyspnea, or shortness of breath with exertion. And as the disease progresses and people start to develop right ventricular failure, they start developing other symptoms, like they might have anginal equivalents, they might have chest pain or pressure with exercise, they often feel fatigued, they develop peripheral edema, and as the disease kind of continues to its ominous end stages, they might have presyncope or syncope, cyanosis. So the early symptoms when people are complaining of exertional dyspnea is because the body can't increase cardiac output in the setting of pulmonary hypertension to accommodate exercise. And as the disease progresses later in the course, we have symptoms really of worsening RV, right ventricular failure. So some of you know my mom is French, so I picked a 17th century French novelist. I don't know if anyone wants to translate, but the more things change, the more they stay the same, a famous French quote. And I just bring that up again to say that the workup of pulmonary hypertension has really been the same over the last 30 years. It's really aimed at figuring out why the patient has pulmonary hypertension. And I think the first visit or two with a specialist in pulmonary hypertension, I think, is where things can go off the rails the most. It's really important that we accurately classify the disease. So this is the World Health Organization classification scheme of pulmonary hypertension. And I know it's probably a little hard to read, but I think the most important thing is, so Group 2, pulmonary hypertension owing to left heart disease, and Group 3, pulmonary hypertension due to lung disease, are by far and away the most common. So these are the PH. So we have our systolic heart failure, our diastolic heart failure, valvular disease, particularly aortic and mitral valve. And then our COPD, particular emphysema, interstitial lung disease, particularly pulmonary fibrosis, IPF, sleep disordered breathing, and then we see more and more patients with obesity hypoventilation syndrome under here who go on to develop significant pulmonary hypertension, significant RV dysfunction. And of course, all of you out there practicing know that left heart disease and lung disease are not mutually exclusive. So many patients come to us maybe with diastolic heart failure, COPD, and sleep apnea, and are developing pulmonary hypertension from that. Later on, I'll talk a little bit about Group 4, or chronic thromboembolic pulmonary hypertension, which is a very rare but very interesting disease that a lot of people sort of incorrectly call chronic PE. But I'll talk a little bit more about that. But again, the vast majority of patients are going to have some combination of 2 and 3. Group 1 is really what we specialize in, so pulmonary arterial hypertension. And like we were saying, PAH can either be an isolated disease, in which case it's either idiopathic or familial syndromes, of which some of the genetics have been worked out, or it's the lung manifestation of a systemic exposure illness. So drug and toxin induced, like your fen-phen from the 80s or 90s, your methamphetamine, and then PAH associated with. So connective tissue diseases like scleroderma, very commonly associated with PAH, HIV infection, portal hypertension, cirrhosis, congenital systemic shunts, so your left to right shunts that go on to develop Eisenmenger syndrome, chronic hemolytic anemia, which I'll very briefly talk about later, particularly sickle cell disease. And then worldwide, they say the most common cause of PAH is the liver fluke infection. I have yet to see that, but apparently worldwide that's the most common. And I think it's because of this classification scheme that you should drop the old term primary pulmonary hypertension and secondary pulmonary hypertension. We should just let those terms fade away. And the reason is when you say secondary pulmonary hypertension, it's not clear. Are you talking about PAH because of scleroderma? or you're talking about pulmonary hypertension due to LV failure. So we should really just be specific when we label the disease. We should say pulmonary arterial hypertension associated with scleroderma, or pulmonary hypertension due to heart failure and COPD. And if you can get those terms right, you'll be ahead of probably half my partners and probably all the cardiologists. So I draw this dumb picture for every patient I see in clinic who comes in for a new consult. So I go on and explain to them, in high school or in college, you learn that you had one heart, but we know, I look at it like you really have two hearts. You have a right heart and a left heart, and the lungs sit in between. I explain to them that the cardiologists are really worried about the big muscular side of the heart, the left side of the heart, and that 99 out of 100 times when someone talks about heart disease, they're talking about their big muscular pumping side. But as pulmonologists, we're really interested in the wimpy, weaker right side of the heart that just pumps blood through the lungs. And I go through this in some detail with them, and I show them all the different places along the way that someone can develop pulmonary hypertension. I do this both to educate them, but it also helps me, it reminds me to kind of think through the broader differential diagnosis, and that's kind of when I come up with my diagnostic plan for the patient. So yeah, if it was only this easy, it's really hard to measure the blood pressure in the lung. Maybe someday we'll, have a tool like that. But obviously, echo is our main way to look at the blood pressure in the heart, in the lungs. And I think it's important to remember exactly what echo is measuring and the difference between that and a right heart catheterization. So what echo is, obviously echo is ultrasound. It can't directly measure pressure. So echo is estimating the pressure difference between the right atrium and the right ventricle in systole. And it's doing that by measuring the velocity of regurgitant flow across the tricuspid valve. And so it's really an estimate of the systolic pressure in the right ventricle or the pulmonary artery. And it's important to keep in mind that it's usually a very good estimate, but not always. So some people, just the geometry of how their heart sits in the chest doesn't allow the echocardiographer to see a complete envelope of, that you can see on the bottom of the regurgitant flow. Or for reasons I don't totally understand, sometimes it amplifies the velocity, and it's just an incorrect measurement. And also, as people develop more advanced lung disease, like emphysema or pulmonary fibrosis, it kind of twists the heart. And again, often then you don't get a good estimate. So this is just really a rough guess of how the cardiologists, when they look at the PA pressure on echo, grade the severity. But this is a very rough estimate. So there are other important things on the echo that we look at. Probably the most important thing is the visual estimate of how the right ventricle is doing. So we know normally the LV is a much higher pressure chamber than the RV. So when you start seeing on the echo report that the right ventricle is enlarged and that it's pushing the septum into the left ventricle, we know that's a really ill right ventricle. It's really pressure volume overloaded. And then it's hard on echo. We can't generally measure an ejection fraction like you can for the left ventricle, because the left ventricle beats inward, whereas the right ventricle shortens. So there's not really an easy ejection fraction on echo, but there's a really neat measurement called the TAPSE. And what the cardiologists do is they measure how far the tricuspid valve moves during systole. And as the right ventricle gets stiffer and fails, that valve moves less and less. And so if it moves less than 1.6 centimeters, we say that's RV dysfunction or a stiff failing RV. And there are other more advanced measurements that the cardiologists can make. They can look at the acceleration of blood into the pulmonary artery. And as the pulmonary artery system gets stiffer, you have less acceleration of blood flow. And they can look at something called the fractional area change, which is kind of like an ejection fraction for the RV. So it's really important not just to look at the number, but also to look at how the RV is doing on the echo reports. So the way to really measure the pressure in the right ventricle pulmonary artery is, of course, by right heart catheterization. And this is essential to the workup of PAH. So anytime that we are concerned that a patient has true pulmonary vascular disease, PAH, we're going to go on to a right heart cath to confirm the diagnosis and to help grade the severity. And also, we do a fair number of caths when we're just not sure what the patient has. So in the modern lingo, HFpEF, or heart failure with preserved ejection fraction, or diastolic dysfunction, can be very hard to sort out from PAH in some patients. So often the right heart cath is really instrumental there. And if you communicate with the cardiologist who's doing the procedure and you let them know that's what you're worried about, if they're not sure, they can give a fluid bolus during the cath and see what happens to the pressures on both sides of the heart, and that can distinguish between the two. And then, of course, we got right heart caths sometimes to manage other diseases like advanced lung disease. We're thinking about lung transplant, or advanced heart disease if we're thinking, cardiologists are thinking about ventricular assist device or things like that. So most of you who are younger than me have probably never seen a pulmonary artery catheter. It's hard to believe, but we used to place those in almost all our ARDS patients, our septic patients with renal failure. It's really hard to believe. But that all went away as I became a third-year resident, as all the overwhelming data came out that we were hurting people. But that's a pulmonary artery catheter, and you can see it coming out the right heart and into the right pulmonary artery. And so I think it's important to keep in mind somewhere in the back of your head that while echo estimates the systolic pressure, the definition of pulmonary hypertension is based on mean PA pressure at cath. So this is really the definition of pulmonary hypertension, is a mean PA pressure greater than 25, which is actually pretty high. Most of us in the room are probably in the teens. That's, by the time you get up to 25, that's a pretty high pressure. And then we want to, if we're talking about PAH, we want to exclude left heart disease. So the wedge pressure, sort of an indirect measurement of the filling pressures on the left side, we ideally would like less than 15, because that tells us there's normal filling pressure on the left side of the heart. Most of the definitions now go up to 18. And then we can calculate the pulmonary vascular resistance, or the resistance to blood flow, and it should be higher than 3. And then the cardiologists also measure cardiac output, and they can look for things like oxygen step-ups to help us look for shunts within the heart. And I think it's important to keep in mind that not everyone who meets this definition has PAH. This definition helps exclude left heart disease, but it's still incumbent on the clinician to say that this isn't explained, by their emphysema or their COPD or things like that. So Tricia James gave an awesome talk last week, probably really important on physician burnout, but she did show a picture or two from the Masai Mara in Kenya. So I also got a chance to go to Kenya and work in the ICU in Eldoret. And I got to travel in Tanzania for a while. So this is obviously a lion cub sitting on a rock under a tree. Absolutely beautiful animal. So I'll just give you a couple of cases of pulmonary hypertension to think about. So World Health Organization Group 2, left heart disease. So what are the clues? So when we look at the echo report, we're going to look for aortic and mitral valve function. We're going to look for left atrial dilation. If patients have severe left atrial dilation, we know they've had elevated pressures on the left side of their heart. That's a very strong clue that they at least have some diastolic dysfunction. We're going to look for LV hypertrophy. Sometimes the cardiologist will actually admit there's diastolic dysfunction on the echo. And then advancing age and metabolic syndrome. So when people have diabetes, atrial fibrillation, abdominal adiposity, high cholesterol, all those things, that should really make us think they very likely have diastolic dysfunction. So this was a case I'm not super proud of. 78-year-old woman, diabetes, chronic AFib, moderate sleep apnea. She was referred to me from an outside cardiology group, moderate RV enlargement, RVSP 62, normal LV function with hypertrophy, severe left atrial enlargement. She was cathed. and had these numbers, mean pressure 35, wedge pressure of 18, so she kind of meets the definition. I was not super inclined to treat her, but I got kind of badgered into it. So we started her on some pH therapy, I think on sildenafil, and she actually did really well for like 6 or 7 months. And then unfortunately she was hospitalized a couple times for severe pulmonary edema, pleural effusions. And if you think about it, the reason this happens, so she clearly has diastolic dysfunction. And the reason they get into trouble when you treat them is I give her something like sildenafil, Viagra, that relaxes her pulmonary circulation, increases the blood flow through the lungs. Well, it ends up in this stiff left atrium, left ventricle, and it can't accommodate it. So when they get a little bit of volume overload, it just backs up in the lungs as pulmonary edema. So that's why the like getting the classification right is so important. So WHO group 3, the lung disease. So obviously obstructive lung disease, COPD, particular emphysema, often associated with pulmonary hypertension. We're going to find that out with pulmonary function tests, CT scan of the lungs. Same thing with ILD, IPF, and other interstitial lung diseases, very common. So again, we're going to see restriction on pulmonary function tests. We're going to see it on CT scans. And then obstructive sleep apnea and chronic hypercarbia. Oh, I think it was a typo, but like obesity, hypoventilation. So we're going to get that with ABG and polysomnogram or sleep studies. So another case, a really nice 52-year-old guy, BMI 64, came to see me, was super plethoric, red, falling asleep in the office, hemoglobin of 16, echo with our severe RV dilation, right ventricular systolic pressure of 84, so really high. Checked a ABG on room air, and he's graduated out of the 50-50 club in the PCO2 of 66, so severe chronic hypercarbia. So I told him, dude, you need a sleep study, but I think we should also do a right heart cath. And he said, yeah, the right heart cath does not sound good to me. Let's just start with the sleep study. So I was like, okay. So we got a sleep study. It's just severe sleep apnea, and he was like an anaerobe. He was like a rock during sleep. So most of the time he's desaturated. So we ended up getting him, and at this point I again tried to talk him into a sleep study, into a right heart cath. I was like, we're going to treat your sleep apnea, but I think you have pulmonary arterial hypertension too. And he refused again. So we got him 6 months of just plain old CPAP, and he comes back, his echo, RVSP 42, right ventricle normal, and it felt great, diuresis like 50 pounds. So a really good example of type 3 pulmonary hypertension due to obesity, hypoventilation, sleep apnea. So I don't want to give you the impression that all patients have group 2 or 3. So when should you start thinking that this patient has group 1 or true PAH? So I think most important, if they have absence of severe left heart disease and lung disease, we really ought to be working them up. Obviously, you can have mild diastolic dysfunction, mild COPD, and develop PAH. So I think absence of severe left heart and lung disease. Connective tissue, very common. So scleroderma in particular, any of the scleroderma spectrum of diseases, and then lupus to a lesser extent, and then diseases like rheumatoid arthritis, much less. But if people have that phenotype of Raynaud's esophageal dysmotility, we really ought to be thinking that they have PAH. Congenital heart defects is really interesting. Obviously, the pediatricians, see the VSDs and all that. But as adult physicians, we see a lot of atrial septal defects. And a lot of the people with ASDs don't go on to develop Eisenmangers or right to left shunt until their 40s, 50s, or 60s. It's a much more slowly progressive disease. So sometimes we have to ask the cardiologist to, do an echo specifically looking for right to left shunt ASD, because they don't always show up on just the plain surface echoes. Portal hypertension, if you work in a liver transplant clinic, about 5 to 10% of referrals for liver transplant will have pulmonary arterial hypertension. HIV infection, probably about 5% or so of people with advanced HIV will develop pulmonary arterial hypertension. Fen-phen is finally kind of fading out, but we still have a couple of patients who are exposed to that. And then in East County, I just assume every patient I have is doing meth, probably about half my patients. family history, and then I'll talk about venous thromboembolic disease. So if they have any of these things or absence of severe comorbidities, then we ought to at least be thinking, do they have PAH? So I'm just going to take a small sidestep into chronic thromboembolic pulmonary hypertension. This is a fascinating disease, or WHO group 4. This is, like I said, often incorrectly called chronic PE. But what we know is the vast majority of acute pulmonary emboli resolve, or if you get a CT scan a year later, they might have a local injury in one of the pulmonary arteries. But a small number go on to develop a generalized pulmonary vascular injury. And for reasons I don't think anyone really understands the pathophysiology, but it's like a finger growing into gloves. So you get this propagation of white, fibrinous, like really dense material that grows on both sides of the pulmonary vasculature and just physically blocks it. If you read the literature from specialty referral centers, they say 5% of all acute PEs will develop this. I think the bigger studies in non-referral centers, it's probably more like 1 in 1,000. But we do see it. And the risk factors are higher RV pressure and more RV dysfunction on presentation and recurrent events, particularly if they've clotted through anticoagulation. And it's really important to remember that the ventilation perfusion scan is more sensitive than CT scan for this disease. So obviously, CT angio is the way to diagnose acute PE. But in the chronic setting, when we're looking for this disease, VQ is more sensitive. And so the reason, as a specialist in pulmonary hypertension, I can never miss this disease is it's potentially surgically curable. This is actually a surgery specimen from San Diego where they specialize in this. And they do a true pulmonary endarterectomy. They put people on cardiopulmonary bypass for, I had a patient who was on bypass for like 16 hours. They dissect open the pulmonary arteries out to the second or third generation, and they very carefully peel this fibrinous material out, and then under the microscope, they sew these things back together. There's obviously a very complex preoperative evaluation to make sure that the patients are good candidates who are going to benefit from the surgery. If they're not surgical candidates, the therapy is really the same as PAH. And a few patients will need PAH therapy even after surgery. But it's really an amazing thing. I saw a patient yesterday in clinic who I really thought was going to die before his surgery. He was syncopizing, who is now riding his bike 50 miles a day. So don't memorize this slide. I'm just putting this up there just to say that really the workup for pulmonary hypertension should be directed, to individual patients, and there's no one-size-fits-all scheme. But of course, the echo is sort of the starting point for working the disease up. We're going to decide, do they need to be worked up for congenital heart disease, things like that. Almost all the patients I see have already had a CT angio, so I'm deciding, do they need a VQ scan? Am I concerned about chronic thromboembolic disease? They're all going to get pulmonary function tests. Most are going to get sleep studies. Most are going to get serologies like HIV, looking for scleroderma, looking for cirrhosis or hepatitis C infection. And then if we go through all this workup and I still think they might have PAH, we're going to go on to a right heart cath. So just from a primary care perspective, when and who to refer, obviously if they have RV dysfunction, pulmonary hypertension without coexisting conditions, we want to see them. If they have severe, moderate, or severe RV dysfunction, pulmonary hypertension, they only have mild coexisting conditions, we should see them. Previous history of PE, DVT, and of course anytime you're unsure of why they have pulmonary hypertension. That's really our job to help you sort that out. And in the modern era, even though we know so much about pulmonary hypertension, there's still about a 3-year gap between symptoms to diagnosis, probably because the workup is so complex. So this is from my backpacking trip this summer. My friend and I had just spent about 3 hours wandering in the snow in a scree field till we finally found the trail again in this saddle. And I believe we're looking at the Quinault River drainage in the Olympic Peninsula there. Absolutely beautiful. So I'm going to switch gears now and really talk about PAH for the rest of the time. So most of what we know about pulmonary arterial hypertension, a lot of it comes from this NIH registry in the 1980s. And this was just a cohort observational study of only 187 patients. And this was in the pre-treatment era. So this is where we define the natural history of the disease. And then a lot of what we know now is from the REVEAL study, which was done throughout the United States. And it was an observational, just cohort study again, but now kind of in the modern treatment era of about 2,500 patients. REVEAL, if we look at why people develop PAH, about 46% have idiopathic and 2.7 had familial syndrome. So about half, it's an isolated disease just attacking the pulmonary vasculature. The other half have associated disease. So about half of them have scleroderma. About 20% have congenital heart disease. See, about 10 have HIV. And then drugs, toxins, about 10% nationally. Again, our practice, this one is much higher. And also probably more cirrhosis too. Again, you don't need to memorize this slide at all, but just what this shows you is that the progression, survival in the disease, it does matter why you have it. Idiopathic is kind of in the middle. And then the people who do the worst, the bottom survival curve is scleroderma. They have the most vicious, fast progressive disease. So if you have scleroderma patients, they really ought to be screened yearly for PAH. And then the people who progress the slowest are generally the congenital heart disease. Like I say, it can take them 50 years to show up. So the other place that WHO comes into this, so we have the WHO diagnostic group, but of course the WHO functional class 2, which they just stole from the heart failure crowd. It's really the same. So class 1 is no symptoms. I've yet to see that patient. Class 2 has symptoms with kind of moderate activity. They might have mild shortness of breath with activities of daily living. Class 3, they have more moderate symptoms. They maybe have moderate to severe dyspnea with ADLs. They might have trouble walking up a flight of stairs. They might have mild RV dysfunction, peripheral edema. Class 4, it's like your class 4 decompensated heart failure. They have rest symptoms, and they have severe RV dysfunction symptoms. So they're the ones who are having syncope, palpitations, decompensated edema. Not surprisingly, again, from the REVEAL registry, symptom class 4 patients have very high mortality, and class 1 is better. Not surprising. So as a clinician in pulmonary hypertension, I really know the most about these 3 pathways of disease, and that's because this is where we have treatments. So prostacyclin was the first treatment pathway for pulmonary hypertension. And it was noted in the 70s that people with PAH underproduce prostacyclin, and they underexcrete the breakdown products of prostacyclin in their urine. And prostacyclin does everything good for pulmonary hypertension. It causes vasodilation of the pulmonary circulation. It decreases smooth muscle proliferation around the arterioles. It's a right heart inotrope. It inhibits platelet aggregation. It does everything good. So the very, very first treatment for pulmonary arterial hypertension was epoprostenol infusion, which is still given by continuous IV infusion 24 hours a day. We now, as we'll talk about later, have a lot of different options for treating the prostacyclin pathway. In general, this is still the most complex and expensive pathway to treat. Historically, the next pathway was endothelin. So endothelin is a hormone that does everything bad for pulmonary hypertension. It causes vasoconstriction, it causes proliferation of smooth muscles around the small arterioles, and it sort of sets up a bad hormonal milieu for the RV, causes bad RV remodeling. And so the very first oral therapies for pulmonary hypertension was actually bosentan, which is a drug that blocks the endothelin receptors. So we now have several endothelin antagonists that we can use. And then nitric oxide was the next pathway that came along. So nitric oxide, similar to prostacyclin, does everything good for the lungs. It vasodilator, anti-proliferative, really good drug for the lungs. So we still can't really give nitric oxide, but the first drugs in this pathway were the Viagras, or the PDE5 inhibitors. And I'll just mention, historically, before there was treatment, L-arginine is the amino acid precursor to nitric oxide. So pulmonary hypertension centers would give people L-arginine candy bars, which apparently tasted really awful. The one, I'll just mention really quickly, sickle cell disease, because it was worked out by a chief resident at OHSU, who's now head of pulmonary somewhere. I think at Pittsburgh. The reason, at least one of the reasons people with congenital hemolytic anemias like sickle cell develop pulmonary hypertension is hemoglobin breakdown products in the blood scavenge nitric oxide. So just to briefly go over the pathology of PAH. So in the early stages, you have endothelial dysfunction, vasoconstriction. As the disease progresses, you get proliferation of the smooth muscles around the small arterioles in the lung. You get inflammatory cells into the arterioles, and you get intimal proliferation around the vessel. And then later in the disease, we get these plexiform lesions, which are these bizarre capillary, weird blood channels that form around the blood vessels. And you get in situ thrombosis or platelet aggregation. So this is just a picture of a healthy pulmonary artery, very thin walls, very low resistance. This is obviously a very diseased vessel with a lot of smooth muscle proliferation, intimal proliferation, and in situ clot formation. And that's our only cannula for blood to flow. So you can imagine why this person's short of breath. And then these are plexiform arteriopathy, these weird blood flow channels around the main vessel. Looks kind of like a kidney to me. But so you know, what happens in PAH is early on, the pulmonary pressures are rising, but the RV kind of compensates and the patients feel okay. Then as we go into you know, class 2 symptoms, they're starting to develop some RV function. They get shorter breath with activity because they can't keep up the cardiac output. And then finally in stage 3 and 4, the RV is starting to fall off a cliff and not able to keep up. So obviously the whole goal of therapy is to, you know, move this way. So there's now a dizzying array of medications that we have access to. So epoprostenol, I mentioned, was the first drug approved in 1995. Bosentan was the first pill in 2001. And then you can see how many drugs have been approved you know, in the last 10 years or so. So compared to IPF, where we have 2 drugs, you know, treatment of PAH is pretty complicated. So we like to think we're doing a good job. We probably are. The bottom line is the predicted survival from that NIH cohort study. So this was in the 80s before treatment. So in the 1980s, at year 3, you had a 50% chance of being alive. And at year 1, you know, a third of patients had died already. So this is REVEAL data. And they took patients from the REVEAL database that matched those in the NIH cohort study. And they looked at their survival, and we seem to be doing better, although again, at 5 years, we've still lost about a third of our patients, so it's still a very deadly disease. So definitely don't memorize this slide. The only reason I put this up is to emphasize that there is absolutely no clinically driven algorithm for how to treat PAH patients. It's really expert opinion, unfortunately. So the key treatment goals, we of course want to improve quality of life, survival. We want people functional class 1 or 2. We want them exercising, improved hemodynamics, and we want to remodel the right ventricle, just like in LV disease. We want to remodel the LV. So all patients should be on salt restriction. They want to avoid living at high altitude, even though Colorado is one of the main referral centers. We don't want them to smoke. A lot of them will be on diuretics. Some patients will be anticoagulated, and they should all be exercising, of course. But so the specific treatment, so nitric oxide signaling. So nitric oxide diffuses into the endothelial cells and the smooth muscle cells, and it turns on this enzyme, this guanylate cyclase, that turns GTP into cyclic GMP and encourages normal vascular tone. So patients with PAH they underproduce nitric oxide, so they don't make enough of this signal. But sadly, they also overproduce phosphodiesterase 5, and PD5 comes in and chews up cyclic GMP. So not only do they not make enough cyclic GMP, but it doesn't last very long. So the first drugs that came around in this pathway are the PD5 inhibitors that come in and block PD5. So we don't make more nitric oxide, we still don't make enough cyclic GMP, but we kind of amplify the effect. So the 2 drugs we have there are the sildenafil and tadalafil. These will be the last drugs I talk about that are even remotely affordable. Generic sildenafil is about $8,000 a year. And tadalafil or brand name Viagra is about $15,000 a year. So these are the only affordable drugs we have. They have kind of the fewest side effects out of all the drugs. Really interesting drug just approved a few years ago, riociguat, also works on nitric oxide signaling. And what it does is it takes that enzyme, that guanylase or guanylate cyclase enzyme, and it sensitizes it to nitric oxide. So it sort of amplifies, again, the nitric oxide signal. And it can also turn the enzyme on directly, so it can cause vasodilation in the absence of nitric oxide. This drug is around $10,000 to $12,000 a month. Has a lot of side effects. It has to be titrated by a visiting nurse until they get up to the full dose. But a lot of people feel like this drug is probably more potent than the Viagra, Cialis drugs, and again, works in the nitric oxide pathway. So again, endothelin does everything bad for the lungs, and we know it's overproduced in pulmonary arterial hypertension, so we want to block all these effects. So right now we have 3 endothelin antagonists on the market, bosentan, ambrisentan, and macitentan. These guys are also probably around $11,000 to $12,000 a month. They have pretty few side effects. They're really well tolerated, kind of like the Viagras, but are quite expensive, and they need lab monitoring. And then finally, the prostacyclin pathway. So again, prostacyclin does everything good for the lungs. Vasodilates, helps the right heartbeat better, inhibits that in situ clot formation. And there are now a dizzying array of prostacyclin options, so it's very hard to know which road to go down. Epoprostenol is, again, the first treatment available, and it's given by continuous IV infusion. Patients go home with an infusion pump. And then if you notice treprostinil, which is a longer half-life, prostacyclin can be given IV, sub-Q, inhaled, and oral. Maybe the only drug that's given by 4 delivery routes. And we have a lot of other options for delivering prostacyclin, including now 2 pills. These guys are very expensive. Treprostinil can easily cost over $200,000 a year. And these are just some of the pumps. This is treprostinil given by subcutaneous infusion, and this is a Flolan infusion pump. So there's very little data to tell us how to treat people. We were proud to be part of the Ambition trial, which was a very large international trial looking at combination of a nitric oxide drug, tadalafil or Cialis, with ambrisentan, one of those endothelin blocking drugs. And this study looked at combination therapy with the 2 drugs versus monotherapy with one of them. And this study pretty clearly showed that you're better off starting with 2 drugs than 1. So probably the standard of care for most people is going to be to start on combination therapy up front. Right now the SWITCH trial is going on, which is looking at that new drug, riociguat, versus the older Viagra and Cialis drugs. Most people think riociguat is more potent than these guys, but this study should answer that question. So when I sit down and I talk to patients and really going over side effect profiles, we're going over cost and coverage with them and trying to figure out what works for them, what works for their lifestyle, what works side effect-wise. No one really knows at what point should we be adding oral or inhaled prostacyclins really early in the course of the disease, or do we wait till you get more severe because they're more expensive? And then most people reserve continuous therapy, the IV therapy, subcutaneous infusion for really, really ill patients. So this was obviously a leopard in a tree eating a antelope that animal drug up the tree. Absolutely beautiful animal. So I'm just going to switch in the final couple of minutes here and talk about the changing face of clinical trials in PAH. And there's a lot of, I think there could be a lot to be learned here about how to do clinical trials. The very first trials were all placebo-controlled monotherapy. The first trial of epoprostenol was actually open label. And these were short trials, 12 to 16 weeks, 3 to 4 months, which for a chronic disease is really, really short. And they used 6-minute walk as a endpoint. So just change in your walk distance. Next generation of studies were very similar. They were still 12 to 16 weeks. They used 6-minute walk, but they included this combined endpoint of time to clinical worsening. but still only 3 to 4 months, really too short to look at a chronic disease. The newest trials are event-driven, so they're lasting 2, 3, 4 years. And they're looking at combined endpoints of clinical worsening. And they're all either add-on therapy or combination therapy. So looking at patients on multiple drugs. So a guy I saw in clinic who had pretty severe pulmonary hypertension, he was a retired engineer, aerospace engineer, and he wanted to know everything possible about macitentan. So that's one of the endothelin drugs. So if you look at how this drug was approved, it's really a Me Too drug. It's the third endothelin drug on the market, so why would we care? But it was done by a super groundbreaking study. So over 60% of the people were already on pulmonary hypertension therapy, and they looked at time to death, hospitalization, worsening disease, transplant referral, or need to go on IV therapy as their endpoint. Study went on over 3 years. So you can see over 3 years a big difference in the approved dose of macitentan versus placebo for reaching that endpoint. And then if you look at death or hospitalization just as your primary endpoint, there's still a big difference between active treatment. Interestingly, there was only about a 20-meter walk distance difference, which is pretty small. So even though these patients aren't having a huge walk distance difference, they're living longer and not being hospitalized. The effect is a little bit smaller if you were already on background therapy, but it's still there. So you know, we can be pretty confident when we add that drug that, you know, we're giving people a clinical benefit. So again, the old days, most of the drugs that we use were just studied in 3 to 4 month trials. But really the modern era, that drug, another drug, selexipag, and the Ambition trial were all done by these 3, 4 year trials. Obviously gain a lot more information. And the REVEAL study also looked at a clinical worsening endpoint, and not surprisingly, they found that if you met the similar definition for clinical worsening, you had about a 20% higher mortality over 1 year. So it's a very clinically robust endpoint that these trials are using. So this was my family. We were about an hour before the totality. We were just checking out our glasses. I think we were just outside of Fossil. That was really amazing. So I'll just end on the Pulmonary Hypertension PHA Association, just a couple of slides. So Pulmonary Hypertension Association, or PHA, it's really a patient and family and healthcare provider group. They do a lot of support and advocacy for patients, a lot of education for patients, support of their families. They do education and conferences both for patient families and for physicians, and a lot of the conferences are combined. So it's a good time for PAH providers to mingle with PAH patients and their families. And they fund research too. It was founded in 1991, I think by the father of a PAH patient. So they came up with this idea of comprehensive care center, which is really modeled on the care of cystic fibrosis patients. And the requirements, among many, it's like a 10-page list of requirements. But you have to have a full-time coordinator that's at a registered nurse level or higher education. You have to provide all treatments for pulmonary hypertension. You have to be part of 3 clinical trials over a 3-year period. And you have to have at least 1 original research publication. And so we went through this process. It actually took us about 2 years to qualify. And I think there are a lot of pros. So it really helped us buff up our practice. So we had to really nail down our hospital protocols for treatment of PAH patients in the hospital. We did that with pharmacy and nursing. We did a lot of nursing education. It really spurred us on to make even more of an effort in clinical research. And one of the requirements is you have to have a pulmonary hypertension ED call schedule. So any patient who shows up in the emergency room on prostacyclin therapy, I'm supposed to get a phone call. So these are all the good things. I think there are some downsides. So no one's shown that this is clinically relevant. It makes sense that it would be. But unlike in cystic fibrosis, there's no data that we do a better job than, let's say, Legacy System does with their patients. One of the things we love practicing in Portland is competition versus cooperation. I think this is a very very good town where we work together. But does something like this spur competition between groups? Probably. And is there an unfair economic advantage to being certified? Do we get more referrals? Probably. So there are some downsides, I think, to accreditation, but we're obviously very pleased to have been selected. We're the first site in the Northwest. So just so you don't think I only like animals in Africa, I'll take my questions with my favorite bear. I ran into him in the Olympic Peninsula about 4 years ago. Yes. Oh, yeah, that's a great question. I think now it's, oh, yeah. The question is, how often are we treating people with like comorbidities who maybe have more than one type of disease? I think in this really modern era, it's probably almost 100%. The number of patients who, like the 30, 40-year-old woman who developed isolated PAH, they are all on treatment now. And the vast majority of patients we see with new diagnosis are now older, have more comorbidities, and we're really trying to sort through, what we think the predominant cause of their pulmonary hypertension is. Yeah. Yes?
Medicare or Medicaid a barrier?
Yeah, so is Medicaid or Medicare a barrier? Actually, I'm not sure why, but I find the state Medicaid programs are some of the easiest to deal with. And Medicare covers these drugs too. Some of the private insurers can be a little more difficult. But I think the numbers of patients on treatment is low enough that I don't know that it quite has hit their radar as much as maybe less expensive but more commonly prescribed drugs.
So if you think someone has PH and you get an echo and it's normal, when do you trust that? When do you send them to you for a right heart?
Right.
When is the echo definitive?
Yeah, that's a good question. So if someone is symptomatic and has a normal echo, what do you do? I think that's where, looking at the other indices of RV function is really important. If they have dilated RV, impaired RV function, things like that, they probably do need a right heart cath. We used to do right heart caths with exercise. That's kind of fallen a little bit out of favor. It's no longer included in the definition of the disease. I think also that's where a cardiopulmonary exercise test can be really helpful. So we bring someone to the PFT lab and put them on an exercise bike, and we can do very detailed measurements of their exercise physiology, look at their blood pressure during exercise, and really the hallmark of PAH is inefficient ventilation during exercise. So if they have like really high minute ventilation per their workload, that's the most sensitive key that we should probably push forward with a right heart cath. Yeah. I think, obvious answer is if you're unsure, but I think clearly if someone has RV dysfunction, pulmonary hypertension without, significant coexistent morbidities, they need to see us. Younger, healthier patient should definitely see us. And I think if people have severe RV dysfunction, severe PH, and they only have like mild or moderate other diseases, we should probably at least see that patient and just sort of work through whether they would benefit from treatment or not. So yeah, I know it's a little wishy-washy, but I think the less that's going on with the patient, the more likely we should see them. Probably don't need to see like the 85-year-old with severe systolic heart failure. I don't have a lot to offer that patient other than maybe a sleep study. Yeah.
Just two simple, questions. The PAH, is there a gender difference? Was that on one of your?
Yeah, it's more, so the isolated idiopathic disease is more common in younger women. And then obviously scleroderma is more common. But some of the other ones are not as gender specific, like the cirrhosis. But yeah, there's definitely more women on treatment than men for sure.
Now, one of the lists there, you mentioned it was the portal hypertension. What's the pathophysiology? How does portal hypertension lead to pulmonary?
I don't really know. I don't know if anyone fully knows. I think some of it was the hormonal signaling from the liver, like endothelin. I think people with cirrhosis have even higher levels of endothelin. Yes. Yep. Yeah. Oh. Right. Yeah, so is there any concern with all the ADHD stimulant therapy? Not that I know of. Yeah, I don't think so, but maybe we'll find out in 20 years. Because certainly they didn't suspect fen-phen either when it came out. Yeah. I think the society guidelines, I think, still say scleroderma should get echoes every 6 months and the other ones once a year. I kind of feel like yearly is probably adequate, particularly I think they're seeing you all the time. So I think a once yearly echo, and then obviously if they're developing dyspnea. Yeah. Sorry.
Since you have so many medication options for PAH, do you just go by clinical symptoms to judge effectiveness of therapy, or do you follow echoes, other physiology?
Yeah. So it's really how do we follow our treatment decisions. So for sure symptoms, we check 6-minute walk test at every visit. So you just have the patient walk up and down a 60-meter hallway and measure how far they walk in 6 minutes. Looking for signs of RV failure, edema, those kinds of things. Most patients will have a repeat right heart cath at some point, sometimes several in their treatment. For sure, if we're thinking of making a major change in treatment, we'll usually repeat a cath. And then I generally check echoes maybe twice a year on patients. And again, I'm usually more concerned not with the systolic pressure that they find on echo, though obviously I look at that, but I'm more concerned with how does the RV look. Like if the RV is still big and dilated and pushing in on the LV, I'm going to talk to that patient about whether they want to go on additional therapy or not. Yes?
Do you do the echoes?
Oh, me? No, I mean, not really. The question is, do we do the echoes? I'm not sure of any pulmonary practices that do their own echoes, because you really need a licensed echo tech to have a readable echo in the outpatient worlds. And then some practices do their own right heart caths, but we kind of leave that up to the cardiology experts who are in the cath lab all day. Yes?
You gave a number for pulmonary arterial hypertension disorder, but not for the very common disease of pulmonary hypertension. What sort of incidence are we talking about?
Oh boy, off the top of my head, I'm not sure what the incidence.
Practice, and I have 2,000 patients. What are the chances that you're going to be finding in there somebody that I completely missed?
Oh, with just garden variety pulmonary hypertension? Oh, I guarantee you have, out of 2,000, you probably have 100, 200. I mean, if you check echoes, just garden variety pulmonary hypertension is so common, particularly as people age. Very, very common.
So are all your referrals from cardiologists?
No, I'd say the majority are from primary care providers. Then probably rheumatology because of scleroderma, and cardiology are the next level. Yeah. Yes? Oh, tough question. I actually didn't talk about that because it's a little confusing. So yeah, if you see a scleroderma patient with an abnormal echo, part of the evaluation is to determine whether it's interstitial lung disease from scleroderma or pulmonary vascular disease. So, those patients are all getting pulmonary function tests, CT scans. Because, yeah, clearly if they have interstitial lung disease scarring, we're going down a different treatment pathway. That's really the only disease is scleroderma that shows up commonly in both the lung disease and the pulmonary vascular disease basket. Can be difficult to sort out. HIV is more straightforward. They generally are not at higher risk of ILD. Out of time? All right. Thank you.